All right, let's jump right in. We're going to be breaking down the management of chronic hepatitis B. My goal here is to take the really comprehensive 2018 AASLD guidance and boil it down into a super practical, step-by-step workflow you can actually use day to day in the clinic.
Okay, so picture this. You've got the lab result right there in your hand. HBsAg positive. It's a really common scenario, and it's that moment where a lifelong journey of care begins. So that now what feeling? We're going to give you a clear framework to answer that question every single time.
So here's our roadmap. We're going to walk through this just like a real clinical encounter. First, what is this disease really? Then we'll hit the 5 key steps: screening, diagnosing, monitoring, treatment, and lifelong care.
Now, before we get into the nuts and bolts, we have to talk about the single most important concept in all of Hep B management. And that's the fact that this disease is not static. It changes. And this right here is the whole ballgame. A patient who looks perfectly fine today might need treatment next year. You can have someone with billions of copies of the virus, but their liver is totally quiet. It's this dynamic, ever-changing nature that explains why we can't just diagnose and forget. We have to monitor.
So that brings us right to step 1 in our workflow: screening. The whole idea is to find people who are infected, often when they feel completely fine, so we can get ahead of the virus before any real liver damage happens.
And you know, who we screen might surprise you. It's so much broader than you'd think. It's not just about specific risk behaviors. We need to be testing every pregnant woman, anyone who's about to start immunosuppressive therapy, and this is a big one, anyone born in a place where Hep B is common, which, by the way, is most of Asia, Africa, and parts of South America and Eastern Europe.
Okay, so you run the screen and you get these 3 markers back. Let's make this super simple. The surface antigen, HBsAg, if that's positive, they have a current infection. The core antibody, anti-HBc, that just tells you they've been exposed at some point. And the surface antibody, anti-HBs, that means they're immune, either from a vaccine or from clearing an old infection. That's it.
So, once you've confirmed they've been HBsAg positive for more than 6 months, we're officially in step 2. Now our job is to play detective and figure out what phase of the disease they're in. And our 2 main clues are the liver enzyme ALT and the HBV DNA viral load.
So first up is the immune-tolerant phase. Think of this as a sort of Cold War. The virus is going crazy, replicating into the millions or even billions, but the patient's immune system is just kind of ignoring it. There's no fight, so there's no damage, and the ALT stays normal.
But then you have the immune-active phase, and this is where the action is. The Cold War is over. The immune system has woken up and is now attacking the virus-infected liver cells. That battle causes inflammation, which makes the ALT go up. This is the danger zone. It's when liver damage happens, and it's the main phase where we pull the trigger on treatment.
And finally, a patient might move into the inactive phase. Here, the immune system has basically won the battle and has beaten the virus down to very low levels. The fighting stops, so the ALT goes back to normal. We call these patients inactive carriers, but, and this is key, the virus is still there, just hiding. It can always wake up again.
So you see, figuring out which of these phases your patient is in is, well, it's everything. Because it tells you exactly what to do next. Do we watch or do we treat? Which brings us to step 3, monitoring. Now, for patients in that immune-tolerant or inactive phase, we usually don't start treatment, but no treatment does not mean no action. It means we're watching them like a hawk. And here's the game plan. For our immune-tolerant patients, we're checking their ALT every 3 to 6 months, just waiting for the first sign that the immune system is starting to fight back. For our inactive carriers, we do the same thing, plus we keep an eye on the viral load to make sure it stays low. This is active, proactive care, not just waiting around. All right, on to step 4, treatment. This is for our immune-active patients, the ones where that battle is raging. Our goal is simple: suppress the virus, get the liver enzymes back to normal, and stop the liver disease in its tracks. So when do we actually start? The guidance gives us some really clear lines in the sand. For HBeAg positive patients, it's a viral load over 20,000 and an ALT that's more than twice the normal limit. For HBeAg negative patients, the bar's a little lower, a viral load over 2,000 with that same high ALT. These are our classic triggers to start therapy. So we know when to treat, but what do we treat with? Well, this is where the 2018 guidance was a really big deal. It added a brand new first-line drug to our arsenal, and it came with some major safety improvements. So let's compare the older tenofovir, TDF, with its newer cousin, TAF. Think of TAF as a kind of smart drug. It's designed to deliver the medicine directly to the liver cells more efficiently. The result? You get the exact same powerful effect on the virus, but at a much smaller dose. And that means it's way gentler on the kidneys and bones over the long haul.
So here's our modern toolkit. We have entecavir, TDF, and now TAF as our go-to oral meds. Pegylated interferon is another option. It's a finite course, which is nice. But honestly, the daily pills are what we use most of the time. Now, TDF is still the top choice for pregnancy just because we have more safety data. But for a lot of other adults, TAF is now the new standard. And that leads us to our final, and maybe the most important step, lifelong care. Because starting someone on a pill isn't the end of the story. Not even close. Managing chronic Hep B is absolutely a marathon, not a sprint. For every single patient, there are 3 things we can never, ever forget. First, we have to keep screening them for liver cancer. Second, we have to think about special situations, like pregnancy. And third, we have a public health duty to prevent them from passing the virus on to anyone else.
Okay, let's lock these in. These are the absolute must-dos. At-risk patients need a liver ultrasound every 6 months, for life. And this is so important. Hepatitis therapy reduces the risk of liver cancer, but it does not make it zero. In pregnancy, if the viral load is high, we use TDF to prevent transmission to the baby. And finally, you have to test and vaccinate every single household and sexual contact. No exceptions.
You know, if you remember just one thing from all of this, let it be this quote directly from the guidance. It says it all. The disease changes, so we have to keep checking labs to know what to do. It's that constant vigilance that lets us make the right call at the right time.
So in the end, this is about so much more than just prescribing a pill. It's about a partnership. By really understanding these phases and using a workflow like this, you're not just managing a virus anymore. You're guiding a real person through a lifelong journey. The only question is, are you ready to guide them through every phase?